everyone. My name is Teddy Milgram. I'm happy to welcome you to the 8th Annual Cannabis in Practice webinar series hosted by Washtenaw County Health Department. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. This live webinar has been approved for 1 general social work credit, 1 MACP specific credit, 1 Mishwa CHW credit, and 1 CHES credit. If you are requesting any of these continuing education credits, you are required to attend the full session. Attendance will be verified through Zoom Analytics. A completed post-webinar evaluation is also required to receive CE credits or a certificate of general attendance. A link to the evaluation will be shared at the end of the session. Please note that the evaluation survey must be completed within 7 days of the session for which you are requesting credit. Certificates will be sent out via email within 30 days. Once you receive the email, you will have 30 days to download the certificate. To review some housekeeping notes, all participants will be muted throughout the session. If you require a live transcription, please select the Show Captions function. If you don't see it, resize your window to be wider. Please ask all questions for our speaker through the Q&A function, which can be found at the bottom of your screen. We will have time at the end of the webinar session for the speaker to answer questions. This webinar is being recorded, and the webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. None of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. So with that, I'm pleased to introduce today's speaker, Dr. Devan Kansagara. He's a professor of medicine at Oregon Health and Science University. He practices and teaches internal medicine in the VA Portland healthcare system. His work is evidence-based medicine, has focused on improving the translation of evidence to practice through evidence-based health policy, clinical guideline development, and data use innovations. He has done health policy and guideline development work for the state of Oregon, the American College of Physicians, and the American Society of Addiction Medicine. He previously directed the VA Evidence Synthesis Program in Portland and led work designing and evaluating innovations in care transitions and the patient-centered medical home. He's currently the principal investigator of the Systematically Testing the Evidence on Marijuana STEM project, whose goals are to empower clinicians to have evidence-informed discussions with their patients and to facilitate more health outcomes research on cannabis. He received an MD from the University of Connecticut School of Medicine, completed residency training and his chief residency at Yale University, and received his master's in clinical research from Oregon Health and Science University. So with that, we will turn it over to Dr. Devan Kansagara for his presentation.
Hi, nice to be with you all. Hopefully you can hear me. And I will share my screen and get going here. So, and then let me just pop into the slideshow here. Okay. Can you see the slides?
Yes, looks great.
Okay. All right, here we go. Um, so we're going to cover a fair bit of ground, but I'll make sure we leave time for questions. So there are parts where I'll move kind of fast, but we'll send the slides out later, and there's references for everything, and please do ask questions. We'll get into a little bit about why people use cannabis, some basics around cannabis and pharmacology, spend some time on what we know about cannabis, both benefits and harms, harm reduction strategies, and then if we have time, I'll introduce you to our STEM project, which is a resource for clinicians. Let's see. Okay, so usually when I give talks like this, I want to remind people that this has been the subject of a polarized debate for a long time in this country. It's been called the most dangerous drug in America. It's also been heralded as having all sorts of amazing properties, such as curing cancer and other things. Obviously, neither of these extremes is true. And our job as clinicians is to help our patients understand what we do know and what we don't know and how it impacts their health. And as Lincoln said here, this may or may not be true. It was on the internet, so it was probably true. Okay, I'm not going to spend a lot of time on this, but this is a brief history of cannabis in the United States. And this is just to remind people that, this does exist in this larger kind of historical, sociopolitical context where cannabis or marijuana had, some less good overtones early in the 1900s. It was associated with migration related to the Mexican Revolution, and there was some troubled history around cannabis and cannabis regulation related to that. And you know, kind of sliding into the war on drugs and all that came with it. And then we started seeing legalization in 1996 with California passing medical legalization. And now we're at a state where it is legal for recreational use in 24 states plus DC, and an additional 14 states where it's legal for just medical purposes. So the vast majority of people in the United States now can access cannabis through dispensaries. But it's worth, kind of remembering how we got here. Um, so cannabis use and cannabis itself has changed a lot in the last couple decades. It's more accessible and more used than ever. About 1 in 5 US adults has used in the last year. Over 4% of all adults use daily. That daily use rate is higher amongst young adults. Its potency has increased markedly over time. The cliche, it's not your parents' cannabis, is true. It's a multi-billion-dollar industry, so that means there's a lot of financial incentive around the industry and whatever that kind of money means in terms of promotion of health benefits. And as I said, the majority of our patients now live in states where cannabis is legal for recreation and medical use. And by the way, we use the term adult use now for instead of recreational use, but that term is fine too. So why should we care about this? Even if we're not necessarily going to sign certification, medical marijuana certification, why should we as clinicians care about this? It's because we're going to see patients that are using it. We can and should play a role in counseling patients about its use in a way that's tailored to their needs and clinical context. And there's a lot we can do to help people. So our role is to ask, advise, answer questions, apply evidence to individual patient comorbidities, risk factors, medications, and so forth. And the and for myself, I work in the VA, so we're not allowed to sign medical marijuana certifications. But the way this works in most of the country, it varies from state to state, but nobody really prescribes cannabis outside of a few FDA approved formulations, which we'll talk about. Rather, what you do is sign a certification saying that marijuana in this is authorized for the use of a medical condition that you say the patient has. This list of conditions varies from state to state. Okay, so we need to do a better job asking our patients about use. If we don't ask about use, then we don't invite the conversation in the first place. So one of the take-home points is just get used to asking patients about it in a non-judgmental and kind of routine way. Use has increased while perceived risk has decreased, and people want to talk to their providers about cannabis, but many providers don't discuss it, and patients instead get information from dispensaries. Dispensary staff are not well equipped to provide the kind of individualized counseling of risks and benefits that one would expect in a clinical setting. So we had worked with some colleagues at the University of Pittsburgh and did a nationwide survey of frontline dispensary staff workers, just asking them about their backgrounds and what kinds of advice they provide. And not surprisingly, these are largely retail establishments. They don't necessarily provide the kind of nuanced discussions that we might want to see in a clinical setting. Okay, so why do people use cannabis? Well, if you ask people for medical use purposes, by far and away, chronic pain is the most common indication, an order of magnitude beyond all the others. Others include multiple sclerosis-related spasticity, cancer-related symptoms, glaucoma, chemotherapy-induced nausea and vomiting, and PTSD. And if you ask them about symptoms that people are using it to treat, pain, anxiety, depression, and insomnia rise to the top. And as I said, the reason we use the term adult use is partly because the line sometime between medical and recreational use is a little bit blurred. Most people still use it recreationally, but those that use it medically report using, many people that use it medically report using it for both medical and recreational purposes. And frequent non-medical use is now more common among users with pain than without pain. And there are certain regions in which this kind of blurring of the line may be more common. This is a great paper from 1970 in Nature. And what this person did is very simple, basically just ask people to use marijuana and ask them about their experience and recorded it. So it's kind of a fascinating 2-3 page paper. And it kind of illustrates some of the from the patient perspective, what it might be doing for them. One person says, I lose awareness of most of my body unless I specifically focus my attention there or some particularly strong stimulus demands my attention there. Pain is easy to tolerate if I keep my attention elsewhere. So these are also, there's another set of studies looking at how cannabis might affect pain. And it turns out that it may have more to do with the affective response, meaning how are you dealing with the pain or processing the pain in your brain rather than pain signaling. And some of these quotes kind of put some voice around that. One of my favorites is when I move about or dance, my motions seem exceptionally smooth and well coordinated. Some of these things also point to some of the trade-offs. My memory span for conversation is somewhat shortened so that I may forget what the conversation is about even before it has ended. Whatever mood I was in before turning on becomes greatly amplified. So if I felt let down, I feel really bad. And if I felt good, I feel really very good. Okay. So switching gears a little bit to terminology. The three names in the title here are from a glossary of different nicknames for cannabis. There's dozens of these. I don't think you'll see most of these in common use, but cannabis, marijuana, weed, pot. Use whatever term is understandable by your patients. Cannabis refers to the plant. Cannabinoids or any chemical that interacts with cannabinoid receptors, and these are the active constituents of the plants. They can be derived from the plant or they can be made synthetically. Terpenes, which we won't really talk about, are another group of chemicals in the plant that are responsible for the flavor and aroma of cannabis. Some people think they may also exert clinical effects in combination with cannabinoids. People talk about this entourage effect. How much that exists and what kind of clinical role it plays is still to be worked out. And hemp, as most of you know, is the fibrous part of the cannabis plant. And legally in the US, it's defined as having less than 0.3% THC. Speaking of THC, so the plant Cannabis sativa has dozens, probably close to 140 different compounds in it, many cannabinoids. The two most relevant cannabinoids for now are delta-9 tetrahydrocannabinol, or THC. And most of you are familiar with this. This is the cannabinoid that's responsible for the high. It has psychogenic effects, may underlie some of the therapeutic benefits. At higher doses can induce anxiety, and at higher doses still can induce psychosis. Cannabidiol, or CBD, it's not associated with the same psychogenic properties. It's thought to perhaps be anxiolytic. It's been heralded as good for all sorts of things. In our grocery stores, you can get CBD for all sorts of indications. Almost all of these are poorly studied. This is a diagram from a review paper which we published earlier this year in JAMA-IM. So the panel on your left shows where the CB1 and CB2 receptors are located. So green is CB1. CB1 is what THC attaches to. And you can see that CB1 receptors are concentrated in the central nervous system. And then the panel on the right shows where they're concentrated and how their concentration might underlie some of the clinical effects of THC. This panel is meant to illustrate the fact that people talk about the endocannabinoid system, which was just discovered in the 90s, so people are still learning more about it. The panel on your left shows that it has a tight feedback loop. It's a homeostatic mechanism. So when you release these neurotransmitters, there's a quick and local off cycle. So in other words, the endocannabinoid system is very hyperlocal and tightly controlled, and the neurotransmitters are rapidly dissipated. That's much different than the effect of an exogenous cannabinoid like THC. Its effects are global and persistent. That's shown in the panel on the right. So, sometimes people will use analogies with the endocannabinoid system to extrapolate to what the expected effects might be with something that's acting on the endocannabinoid system like THC. But it's hard to analogize because the effects are not one-to-one and because the THC effects are more global and persistent. Another take-home message is it's misleading to think of cannabis as a single homogeneous substance. So in fact, the sentence cannabis does X, Y, or Z is kind of meaningless. So we really need to get in the habit of being as detailed as we can be. So there's all sorts of cannabis preparations. Cannabis flower remains the most commonly used form of cannabis. It can be smoked in joints or spliffs. On the bottom there are a variety of vaping implements. There's every form of edible out there. This is hashish on the top. And then there's all sorts of tinctures and concentrates where the concentration of THC gets up to 60, 70%. And the top right is ultra concentrated form called wax or shatter. And right below that is a dabbing rig. So dabbing is a form of use where you heat up a titanium rod, essentially touch the wax or shatter to it, and then inhale the resulting smoke, and that produces THC concentrations upwards of 90-95%. So, this dabbing is much different than taking a 5 milligram gummy. Um, and the clinical effects are likely much different. Bottom right are three of the FDA-approved cannabinoid formulations. Dronabinol and nabilone are FDA-approved synthetic forms of THC approved for HIV-associated cachexia and chemotherapy-induced nausea and vomiting. And Epidiolex is a ultra-purified form of cannabidiol that's approved for some childhood seizure disorders that we'll talk more about. And then the bottom center here is Sativex or nabiximols. It's an oromucosal spray. It happens to be probably the best studied formulation of cannabis for chronic pain. And we'll talk more about chronic pain here in a second. It's licensed in multiple European countries, but not in the US. Pharmacokinetics. So the purple line is smoking or vaping. Bottom line is quick, rapid on, rapid off. And then the green line is oral. So edibles take a while to take effect, and then their effects may linger for longer. And so for cannabis naive patients, it's important for them to know that because you can accidentally dose stack and get in trouble with taking too much after not having felt much in the first hour or two. Couple things to highlight with regard to route of administration. We'll talk more about smoking a little later. Vaping may produce higher blood THC concentrations for a given dose than smoking does. Oral use, there's a first pass metabolism effect, and there's an oral metabolite of THC called 11-hydroxy-THC, which may have a more powerful psychoactive effect. A lot of people ask about topical forms, and these remain pretty poorly studied. What about dosing? So it's hard to say much about dosing as we continue to learn more. Some states have started to put out what they think is a single dose. These usually range from 5 to 10 milligrams. The NIH a couple of years ago defined a dose of THC for research purposes as 5 milligrams. Nabiximols, which is the spray I mentioned, each spray contains about 2.5 milligrams each of THC and CBD. And in the trials, the median effective dose in the neuropathic pain trials was about 20 to 25 milligrams of THC a day. And there's case series of people landing in the hospital with acute psychosis, and those doses were often about 100 milligrams or so. So one of the other take-home points, one of the challenges with clinical medicine and cannabis in the United States is that in practice, the way people are getting things is through dispensaries. So what's studied are these formulations like Sativex, but they're not what is available in dispensaries. And so we kind of have to approximate and extrapolate effects. And patients are getting we have no control over what patients are getting by and large. I'm going to skip over this, and I'm realizing that I have a slightly older version of this slide deck showing here. Give me 1 second. I'm going to stop sharing my screen. Sorry about this. I will. 1 second. My apologies. And I had made some changes to this while I was doing clinic yesterday, and it didn't get transferred to my Dropbox folder. So my apologies. Okay, now I got it open here. All right. Sorry about that. All right. Where were we? Okay. Um, I already mentioned this. This is from a study now 10 years ago. So the numbers may be off, but the bottom line with these investigators went into a bunch of dispensaries in several states and took samples and studied them under a mass spectrometer and got exact dosages. Bottom line is what people have access to and what they are accessing is largely THC. So the median THC to CBD ratio in dispensaries, at least at that time, was 36 to 1. I don't think it's much different now. Okay, so in terms of cannabis health effects, we don't know whether cannabis is effective for a lot of things. And many of these conditions are listed as conditions for which medical marijuana is approved in different states. Um, so what are the potential benefits of cannabis? And we'll kind of go through these one by one. Chronic pain, particularly neuropathic pain, epilepsy, chemo-induced nausea and vomiting, MS, and CBD for anxiety, maybe. Okay, so I'm going to spend a little time on chronic pain. And what I'd like to do, if you bear with me, is use this as a way of talking more generally about how to take a risk-based approach to medical use. And so here's a quick overview of the evidence on cannabis and chronic pain. There's a visual abstract from our website. And basically what we find is that there are small beneficial effects on pain, but not for function. Best studied formulation is this spray that equal amounts of THC and CBD, and there's some evidence for synthetic THC products as well. What most people use, those still are whole plant formulations, and these remain understudied, or there's some studies now underway. Neuropathic pain is the best studied type of pain, although there's a couple of studies on back pain just from a few months ago that show some promise. As you'll see on the right here on the visual abstract, short-term adverse effects include dizziness, nausea, and sedation. Importantly, most of these trials are short-term, weeks to a few months. We don't have longer-term data. Okay, so this all went into a guideline that we wrote for the American College of Physicians last year. And I'll take you through this a little bit because I think it does provide some structure around how you might think about different patient populations and medical use. Okay, so the first recommendation is that clinicians should counsel patients about the benefits and harms of cannabis or cannabinoids when patients are considering whether to start or continue to use cannabis to manage their chronic non-cancer pain. We felt this should be a recommendation. I mean, it seems fairly obvious, but clinicians aren't always doing this, and so we thought that just getting into the habit of asking about cannabis use and counseling part of practice is worth pointing out. And then we identified several higher risk groups in whom we might want to dissuade use for chronic pain. And these risk groups kind of apply even outside of the topic of chronic pain. Young adult and adolescent patients, patients with current or past substance use disorder, patients with serious mental illness, and frail patients and those at risk of falling. And I'll take you through the rationale for that. Okay, so young adults and adolescents. So this is another take-home point. I think this is a population, that there's starting to be more public health discussion around. And that's because there's emerging evidence that regular cannabis use can have deleterious effects on the developing brain. It's possible that some of these adverse effects could be long-lasting, and these effects are probably exacerbated by high THC cannabis, which, as I already pointed out, is widely available. And I'll take you through these different effects. So cognitive effects on the developing brain. Active frequent use, so people that are kind of using daily or near daily, probably experience at least small neurocognitive deficits. If you stop use, these deficits probably improve. Although there's some studies that suggest there may be longer term cognitive effects, and this could even be seen in IQ testing in those who start using during adolescence and continue using heavily for years in adulthood. So there may be, people that start using at a really young age may be particularly at risk. Cannabis and psychosis. So there's now an increasing number of studies showing this. I'm just showing two examples here. Um, Sorry, my dog is waking up here. Uh, so there's a Canadian study from 2024 that finds that those that start use in adolescence have almost 11-fold higher risk of future psychotic disorder. And this is a study where they followed people for 8 or 9 years. So it's a good long cohort study. The panel on the right shows that um, those with developing brains that continue cannabis use. So you might have an initial exposure during brain development, and that might increase your risk of psychotic spectrum disorder. That risk increases substantially if you continue use into young adult and adulthood. Okay, and so in summary, cannabis and psychosis. Cannabis use is associated with perhaps a 40% increased risk of future psychotic symptoms. I say perhaps because the exact number varies from study to study. There's a dose response effect, meaning, high potency cannabis is probably partly to blame for this. The average age of onset of psychosis was 2.5 years earlier among those who use cannabis compared to those that did not. And of note, there's some information that those with a genetic predisposition to schizophrenia, i.e., those with a first-degree relative who have schizophrenia, may have a particularly elevated risk of developing psychotic symptoms with regular use. So this is a patient population when they're young, which we might want to actively encourage them against use. Cannabis use disorder, about 3 in 10 who have used in the last year is the prevalence. And about half of those with cannabis use disorder have mild disease, while half have moderate severe disease, meaning it has an impact on their life. One thing I want to point out here is that the burden of cannabis use disorder is highest amongst our younger populations and amongst males. So cannabis in patients with serious mental illness, probably not a great idea for a few different reasons. In patients with bipolar 1 disorder, there's now a number of observational studies suggesting that cannabis use is associated with an increased incidence of mania. And then in those with psychotic spectrum disorders, there's an increased burden of psychotic symptoms. Its use in depression and anxiety and its effects over the long term are unclear. Although we do know that high doses of THC can acutely induce anxiety and depression symptoms. So think about that quote I read where somebody said, whatever kind of mood I'm in, cannabis tends to heighten it. So if you're in a depressed mood at higher doses, it might accentuate that. Heavy use, there's also a little bit of data that heavy use may be associated with self-harm in those with poorly controlled depression, particularly in younger populations. And sorry about the dog here. He's about to go out for a walk. So THC-containing formulations increase the risk of dizziness and nausea, which could increase the risk of fall. And indeed, there's some data from ERs that cannabis has been associated with increased rate of injuries leading to ER visits. So counseling against use in those that are high risk for falls is probably a good idea. We advise against use in those that are pregnant or breastfeeding. I'm not going, for time purposes, I'm not going to review this data in detail, but we have a meta-analysis in JAMA Peds from last year, which summarizes this. So there's a large number of studies suggesting that perinatal use is associated with neonatal adverse effects. In terms of smoking, we advised against long-term use of in smoking. And the data here is a little bit harder to pin down. Smoking certainly increases the symptoms of bronchitis, and cannabis contains, when it undergoes combustion, releases some of the same toxins and carcinogens that we are concerned about with tobacco combustion. Although the long-term effects on lung function are not well worked out. The long-term studies we do have are in younger populations that are using infrequently. But anyways, because of these other things, smoking for a chronic condition like chronic pain is probably not a great idea. Other areas of promise, for time purposes, I'm just going to kind of quickly talk through these. Multiple sclerosis, there is low strength evidence. A lot of people with MS who have trouble with spasticity do use cannabis and find it helpful, and there's some data to support that. So even though there's a high placebo response rate, there are studies that support response with cannabis for some patients with MS. Epilepsy, this is kind of a triumph here. CBD, purified form called Epidiolex, is approved for these two forms of seizure disorder in kids, Lennox-Gastaut, Dravet syndrome, and also tuberous sclerosis. And it can reduce seizure frequency by a lot. Cannabis for chemotherapy-induced nausea and vomiting. We have a clinician brief on this on our website. Bottom line is dronabinol and labolone are FDA approved for this indication. They work as well as older antiemetics. We don't have comparative effectiveness data with, kind of state-of-the-art current modern triple or quadruple therapy regimens. However, patients like using cannabis better than they like using all of these prescription drugs. And there's some data to support their use here. There's a whole bunch of other things to consider, which I will briefly summarize here. So cannabis and sleep, you'll hear a lot of people talk about this. It's not as widely studied as one would expect, given how many people use it. The most promising evidence is when you look at subjective sleep quality in patients that have other conditions. So it's been measured as a secondary outcome in, say, chronic pain studies and other studies, in MS studies. There are very few studies in primary insomnia, and these have not been promising. And then when you look at objective measures of sleep architectures, these have not shown benefit when you do actual objective measurement of sleep. I'll just point out this may change as we get to learn about newer cannabinoids. So CBN is an emerging cannabinoid that may be useful for sleep. This is a trial from a few years ago that was promising and suggested a CBN-containing formulation may actually improve insomnia. Cannabis and dementia, there's interest in its use to help reduce agitation. Not a lot of data. Well, there's a study just this year, which I'll just point out just since it just came out this year, which was promising, using dronabinol, relatively low dose, and did show some effect on neuropsychiatric symptoms in those with Alzheimer's disease. Cannabis and cognition, the bottom line here is that it clearly acute use negatively impacts cognitive functioning. And I showed you that quote that kind of highlighted that, like while people are using, short-term memory effects are fairly clear. The real question is whether or not there are residual effects. So it seems pretty clear in adults that stopping use, many of these cognitive difficulties go away. And the data we do have suggests that these largely resolved with sustained abstinence. Whether long-term heavy use over a long period of time has downstream impacts on dementia and so on and so forth, we don't really know yet. Cardiovascular effects, I'm just going to skip to the bottom line here. Cannabis is, THC in particular, has noradrenergic effects, right? So it can increase heart rate, supine blood pressure, sometimes postural hypertension. Tolerance to these effects may develop with repeated use. It's unclear whether cannabis use from observational studies increases cardiovascular risk, but the problem is, some of the better cohort studies are in younger patients. Because of the noradrenergic effects, and because at least there's some cohort studies that do have some methodologic issues suggesting some increased risk, I think it's probably reasonable to caution patients who have active cardiac disease, say who have angina or recent MI, against use. Cannabis hyperemesis syndrome, I'm sure many of you have heard about this and or seen patients with this. It's increasingly recognized. It's a form of cyclic vomiting syndrome associated with chronic regular cannabis use. It has this odd feature where people have abdominal pain, and some of these symptoms may improve with hot showering. There's little long-term data on long-term outcomes. There's no known cure for this other than discontinuing use. And discontinuing use can be a hard sell because people think they're using cannabis to treat nausea in the first place. And then you have to say, well, you have to kind of give up use for 4 to 6 weeks, and hopefully your symptoms will improve. Cannabis withdrawal is another thing worth keeping in mind. It may be fairly prevalent. It says can develop up to a week after cessation, probably a couple of days, 2, 3 days after cessation, lasting up to several weeks. That's probably on the extreme end, a few days to a week for most people. But the bottom line is that the symptoms of cannabis withdrawal, anxiety, restlessness, insomnia, and depression, are many of the same symptoms that people use cannabis to treat in the first place. So we can help our patients understand when they might be mistakenly using cannabis. They think they're using it to treat a symptom, but really they're just using it to treat cannabis withdrawal symptoms. Okay, so cannabis is not one thing. There's a need to move discussion from yes, no to how, what, when, how much, et cetera. I think there's some higher risk groups that we know enough about that we can caution against regular use, and I already highlighted those. There may be some potential promising areas for medical use of cannabis, but the long-term balance of benefits and harms is not known. And so, for most of these things, it's probably a late resort treatment. And just briefly, this is our STEM project. It's at cannabisevidence.org. It's publicly available. You can check out the website. There's a bunch of different clinician-facing things on there. We update news articles with regard to cannabis once a month. We've got a bunch of clinician briefs on various topics. We have Cannabis Basics page, which goes through the pharmacology and so forth. The centerpiece of the project are these living systematic reviews. There's 6 of them on there, and we update these at least yearly. And then there's some other things as well. If you're interested, this should take you to a link that allows you to sign up for we send out a monthly digest, which includes the news articles and anything new on the website. So if you want to kind of keep up with what's going on in this, you can sign up for this. I'm going to stop and hopefully left enough time for questions.
Thank you for that wonderful presentation. I know it was a lot of information we were trying to pack into a short amount of time, but hopefully people found it valuable. So we're now going to open it up for questions. Again, we do ask that all questions be submitted through the Q&A function, which can be found at the bottom of the screen. And we will go ahead and feel free to continue to add questions, and I will pick from there to choose a few, or if we have time, hopefully can cover all of those. So the first question we have is, does cognition improve in teenagers who were given marijuana throughout adolescence if they stop?
Well, I mean, I think the short answer is we don't know. I mentioned that one study about lower IQ. So there's at least one study that suggests that heavy use in adolescence, those patients may have a some lingering cognitive effects. Um, so I think the short answer is we don't know, but we do know that cessation does reduce some of the acute effects. And given what we know in adults, I think there is value to telling people that it's likely they'll improve some. I don't know that we can tell people that they won't have longer term cognitive issues down the line if they had used heavily during adolescence, but certainly that shouldn't dissuade people from experiencing some of the benefits of um, cessation of use if they had used heavily during adolescence.
You. Another question we have is, has the current CSA schedule for cannabis hindered research at all, in your opinion? What would be the benefits or harms of rescheduling cannabis? I'm curious because I've heard lack of research as a reason to reschedule.
Yeah. So it's a good question, and as you all know, it was recently rescheduled from Schedule 1 to Schedule 3, and part of the impetus for that is indeed to try to make it easier to conduct research, and one of the other bottom lines is there's a lot left to learn, there's a lot more to research, and one of the reasons there is a lot left to learn is because it has been hard to do research, particularly in the United States because of some of the regulations. How much the rescheduling of cannabis will kind of automatically change the research around this area is yet to be determined. I don't think there's an automatic, it's not like rescheduling by itself is going to change that. I think people also have to um, uh, change some of the research infrastructure. They have to make places that we can get cannabis for research purposes. They have to open that up, which has opened up in the last couple of years to a certain extent. So, anyways, bottom line is that there needs to be some thought put into doing the research, and there are people doing that. We oversee a cannabis research network called ACRC, which now includes over 30 cannabis research centers across the country. And part of that is to try to get people together, collaborating and talking about ways to do more clinically impactful research. There's also the NIH has a new Cannabis Research Resource Center called R3CR just starting this year. And one of its purposes is to try to make it easier to do this research by supporting new investigators, by standardizing products, by trying to make it easier to make products for study available. But rescheduling, I mean, the most immediate obvious effect is actually going to be on the financial side. I believe that the rescheduling will allow dispensaries to have a lower tax burden and to become part of the banking system. So I think it'll have some more immediate kind of non-clinical effects.
The 5 to 10 milligram THC dosing guidance that you mentioned, is that per dose or per day? And does that hold for edibles specifically, given slower onset and easier overshoot?
Yeah, thanks for asking that clarifying question. So this isn't guidance from me. That was just, simply reflecting that there are states that have tried to come up with these doses, and those are some examples. I think for a cannabis naive patient, 5 milligrams of edible THC is going to be a lot, and it might be too much. Um, and so in practice, so that there are some guidelines out there. They're kind of expert-based guidelines to try to help people say, well, there's a lot we don't know, but for people that are going to use, if they're going to use, what are some ways to do it relatively safely? In our ACP guideline document, we have some of those recs, and there's something called the lower risk cannabis use guidelines, which have some practical advice. And they'll say things like, start with cannabidiol, which doesn't have the same psychoactive effects, and then add in low doses of THC, where you might start with 2.5 milligrams for cannabis naive individuals and increase by 2.5 milligrams a day every 3 or 4 days. And they suggest a ceiling dose of 40 milligrams of THC.
You. Um, there's a question about, so what is the best way to accumulate better analytics and statistics on the benefits and risks associated with cannabinoid use? And how long is it likely for that research to take before our knowledge becomes more whole? So I don't know if you maybe in answering this wanted to speak a little bit more about highlighting the STEM website and the research that you guys are accumulating on there for clinicians as a resource as well.
Yeah, sure. Yeah, so I think that there are holes that are, slowly being filled, and some of these are more filled than others. One of the challenges with cannabis, honestly, is that it's been purported to have impacts on health that, span the entire body, like for every imaginable condition. Um, and so there's a lot of gaps to fill in. And so one of the challenges, we actually just drafted a piece on cannabis research prioritization, um, with the notion that we have to pick some targets because there's 100 different things to study, and there's no way to fill in all those gaps. Um, so as you'll see on our website, we have these living reviews on things ranging from cannabis for chronic pain, where there are now, several dozen studies, and there are some things we can say about it. And we update these every year, and so some of those gaps are being filled in. We have one on cannabis and PTSD, another common reason for use. And that's one where we desperately need more studies. Few studies, the studies we do have, haven't shown promise for the treatment of PTSD. But there are some studies underway, including one in the VA. So hopefully some of these will get filled in. If you're curious, on the website, there's a page called Registered Ongoing Studies. So it's a place where you can quickly search for what's being done, what are the in progress studies for cannabis and chronic pain, cannabis and multiple sclerosis, cannabis and whatever topic it is you're interested in. So yeah, I mean, I think it's a fair point. It'll take a while to fill in the gaps. I think there's so many gaps that I don't think you can fill in all of them, but we do need to prioritize the ones that are most important to patients. So PTSD is a good example of one where we really do need more information soon, and there are people taking steps in that direction.
Right, we'll see if we can fit in a couple more questions here. I might have missed this, but why the change in verbiage from recreational to adult use?
Yeah, I mean and to be clear, people still use the term recreational. I think the adult use is partly, I think some in the community feel that recreational may, kind of discount cannabis use or marginalize it. And also to acknowledge that, uh, it's not necessarily clear whether use is recreational or it's treating some symptom. As I mentioned, there's some blurring of that line. Um, and I think you get a sense of that from that nature study and some of those quotes I presented to you, where, what's recreational use, what's found to be valuable for somebody's well-being and where you draw the line. So I think that's part of the reason too. But you can still use the term recreational and people understand it.
All right, I think we have time for hopefully at least one or two more questions. So one, which I think is hopefully pretty straightforward, is it legal to give your kids marijuana?
No. Well, so
And then
yeah, I mean, I don't know. I mean, I don't know anything about how it's enforced, or, I'm not on the legal side, obviously, but yeah, it remains not legal for underage use. Um, Now, Epidiolex, which is cannabidiol for seizure disorders, that can be gotten by a prescription, and that's an exception, but.
and then we have a question about withdrawal. So I had a client using edibles in their 60s, and it took months for some long-term withdrawal symptoms to improve. What can you say about longer-term withdrawal?
Uh, I don't know, honestly. I mean, I can't say a lot. I don't know that we have data months out. I think um, the research on cannabis withdrawal, like I said, suggests that it can last up to a few weeks. I haven't seen data suggesting that symptoms go out many months, but it may be possible, but it hasn't been widely described yet in the literature.
And maybe we actually have time for one or two more. Okay. Some people report indica or sativa have an opposite reaction for me. Does indica really cause increased energy for people, or are they people psychologically convincing themselves because they want to use?
Yeah, so the term indica or sativa are they're supposed to connote like a subspecies of cannabis, but the terms don't actually mean that. There's been so much crossbreeding, and so they've come to basically mean what the expected effect of this formulation is, right? So sativa is meant to connote a strain that's likely to be uplifting and energizing, and indica is more kind of a body high or calming and restful. And so that they're essentially colloquial terms used to describe the expected effects. Probably these effects are more determined by cannabinoid content in the strain. And so a strain that has a lot of THC and no CBD is more likely to be energizing and uplifting, and a strain that has equal amounts of THC and CBD might be more indica. And then there's all these other cannabinoids in there that may influence the effects. But that's kind of what the terms mean. So whether somebody says they take indica and makes them energize, I don't know. One of the challenges, you're going to obviously get a lot of individual variation in the experience too.
Right. Well, unfortunately, I think that's all the time we have for questions today. So I apologize for those that we weren't able to get to. Um, but thank you very much again for the wonderful presentation, and for those of you who attended, for attending today's webinar. We hope you found it both